direct inguinal hernia, is it really a recurrence or is it a new entity? So this is very controversial. So in the future, we really have inguinal hernia. Is it really a recurrence or is it a new entity? Really good. So this is very controversial. So in the future, we really have inguinal hernia. Is it really a recurrence or is it a new entity? So this is very controversial. So in the future, we really inguinal hernia. Is it really a recurrence or is it a new entity? So this is very controversial. So in the future, really inguinal hernia. Is it really a recurrence? If you look at the new size of the hernia, this is very controversial. Sometimes when in the future, really inguinal hernia, is it really a recurrence? If you look at the new size of the hernia, this is very controversial. Sometimes when the future, really inguinal hernia, is it really a recurrence? If you look at the new size of the hernia, this is very controversial. You can have a really inguinal hernia. And here we have the problem when we consider a bulge, just a bulge. When do we consider here we have the problem when we consider this already a bulge, really inguinal hernia. When do we consider here we have the problem there is already a bulge, really inguinal hernia can get this bulge can be symptomatic, so it's controversial. When the bulge is really inguinal hernia, it will be defined even the guidelines. It is not really when the bulge is really inguinal hernia. Come to the surgical side. It's also very difficult sometimes to say is it an infection? Surgical side. So you can go to the website of John Hopkins. Liver pain, tenderness, swelling. These are signs of surgical side infection. Liver pain, as you can see in the slide. Tenderness, it's obvious. These are signs of surgical side infection. Laboratory for testing bacteria. There's a very good publication from the Ventral Hernia Working Group. There's a very good incisional ventral hernia literature and recommendation regarding the grading and technique of repair. The operations are graded low risk and high risk operations for infections. The operations are graded low risk patient, for example, no high risk infections, no operations, very low. Somebody who had previous infections and comorbidity, for example. This grading has to be kept in mind. The definition of the surgical infections, in my opinion, the best definitions are grading given by the Centers for Disease Prevention of the United States. The best services are grading given by the Center. Look it up. They differentiate between superficial incisional surgical site infections, and then here the typical signs of seizure, redness, swelling, tenderness have to be there. But on the other hand, then here bacteria, signs of seizure, redness, swelling. But of course, sometimes cannot diagnose bacteria, then you cannot say it's not an infection. If you have the typical signs of an infection and cannot diagnose other bacteria, then cannot say it's not an infection. And you don't, if you still have the typical signs of an infection and cannot diagnose other bacteria, then cannot say it's not an infection. Then if you still have the typical signs of an infection and cannot diagnose other bacteria, then cannot say if you still have the typical signs of an infection and cannot diagnose other bacteria. Another entity of infection is organs have the typical signs of an infection and cannot diagnose other bacteria. The typical signs have the typical signs of infection. Now I give you some data of the German hernia database. Hernia have the typical signs of infection comes together and operations. Today we have hernia database. All the typical signs of infection and operations. These data. We can see here the complication rates, no complications, bleeding, vascular damage. You can see here the complication rates, no complications, numbers are given. Bleeding here. Vascular damage. You can see here the complication rates, no complications, numbers are given. Bleeding here, vascular damage. You can see here the complication rates, no complications between the intraoperative lesions, vascular, gastral, spleen, bowel, liver, bladder, and others. In this slide, you can see the intraoperative complications, again from HerniaMed database, comparing lab-IPOM versus open sublay operations. And you can see that after laparoscopic or during laparoscopic IPOM operations, intraoperative complications, bleeding and injury of vascular injury or visceral injury are higher than after open sublay operations. Here are the numbers. HerniaMed database after bleed, bowel injury, surgical site occurrences, seroma, infections, bowel obstructions, and others. You can see that the reoperation rate after incisional hernia operations, that means reoperation within 30 days after the operation, is 3.9%. And again, the postoperative complications, comparing lab-IPOM to open sublay. Here you can see that lab-IPOM is more favorable than open sublay. All these postoperative complications occur more frequently after open sublay repair compared to lab-IPOM. And you can see that it is statistically significant. And in this trial, we did compare comparable types of hernias. Another interesting publication, Annals of Surgery, the enterotomy risk in abdominal wall repair, and a cohort of 133 abdominal wall repairs were analyzed, and the conclusion was that 1 in 8 patients undergoing abdominal wall repair suffers inadvertent enterotomy. For me, this is very high. I think this is probably not the data from specialized centers, but still, 1 in 8 patients with abdominal wall repair has an inadvertent enterotomy during adhesiolysis. So take care you're doing adhesiolysis. If it comes to bowel injury or visceral injury, this of course is obvious when you have a bowel perforation during a hernia operation during adhesiolysis. It's clear it is a complication, and it has to be registered like a complication. So there is no doubt about the definition. What is a visceral injury? Again, here in this respect, you can of course discuss: is a seroma defect after adhesiolysis, is it a complication? I would say no, because this is a very frequent thing that happens during adhesiolysis. So the impact of inadvertent enterotomy on short-term outcomes, a publication from the United States, from the American Hernia Society collaborative, and it shows clearly that after enterotomies, the enterotomy rate in complex cases of ventral hernia have an overall incidence of almost 2%. This is an early surgical site infection after an E-milus operation, which we have performed. We have now done more than 3,000 of these operations. Infections are very, very rare. It's extremely rare, but still it happens, as you can see here. And this was a staphylococcus infection, which occurred 12 days after the operation. We had implanted a large piece of mesh. The patient had a quite large epigastric hernia and umbilical hernia, and we implanted a sublate PVDF mesh. The mesh could be preversed with a VAC treatment in this case. This is another entity, late infection with mesh erosion. In such cases, of course, it's clear it's a mesh infection. It's a chronic infection, and the mesh has to be removed. And I'd say it should be removed completely. Very interesting trial from Sweden. Nobeck and co-workers, they published that almost all mesh infections, in all ventral hernia mesh infections, the mesh can be preserved. In 92% of the cases, the mesh can be preserved when you apply VAC therapy. Even sometimes it is necessary that you do the VAC therapy for a very long time. But still, only partial mesh repair was necessary. In no case, a complete mesh repair was necessary. So this trial shows that sometimes you have to be patient and to treat a mesh infection, chronic mesh infection. Another problem which happens after, especially after open component separation operations, the Ramirez operation, this typical skin necrosis, which can be very bothersome for the patient. Mesh migration, mesh migrations are also clear if they are diagnosed. The mesh migration is a mesh migration. The mesh can migrate into almost all the viscera. And mesh infections in ventral hernia repair, a very interesting trial by Buenoyedo from Spain. The risk factors and the risk factors of infections and the risk factors for mesh explantations, you can see here. Buenoyedo came to the conclusion that it's better to remove the mesh completely, because if the mesh is incompletely removed, if an infected mesh is incompletely removed, the reinfection rates are very high, with 50%, as you can see here. Another trial comparing outcomes, partial mesh versus complete mesh excision from Todd Hanniford's group in Carolina. And again, the group came to the conclusion that the mesh should be removed completely, because otherwise the recurrence rates of infections are too high. This is a trial by Mike Rosen with a biological mesh, a 5-year clinical experience with a single-staged repair of infected and contaminated abdominal wall defect with biological mesh. Here, the high rate of wound infection and wound morbidity and the deep wound infections, reoperation rates, early recurrences, and recurrence at 3 years. And comparing biologic mesh versus synthetic mesh, the trial by Majumdar and Novitsky, they came to the conclusion that synthetic mesh in contaminated fields has quite good results compared to biologic mesh. The same conclusion was drawn by Carbonell. So it's obviously not the case that biologics or biosynthetic reabsorbable meshes are better in the contaminated and infected field, but we have to wait for more trials. Here are some of the absorbable synthetic meshes which are on the market. Phasix, for example, seems to have quite favorable results. Another interesting publication, recent publication by Alfredo Carbonell from the United States. He made a trial with irrigation with a combined gentamicin and clindamycin antibiotic solution during incisional hernia operations, and he could show that this intraoperative rinsing of the wound with gentamicin and clindamycin leads to less infections. We do this since many years, since decades. We use gentamicin solution in every incisional and ventral hernia operation with mesh, according to the regime published by Maximo Desin for inguinal hernia repair many years ago. So I come to my conclusion. Prevention, of course, prevention of complication is the best in hernia repair. We should always try this. Standardized and universally accepted definitions of complications and chronic pain are needed. We don't have those standardized definitions, especially if it comes to recurrence. And future trials are needed. And these future trials can only be successful and lead us to better and results and less complications if we standardize the definitions for complications. So thank you very much.
Thank you, Dr. Wolfgang. It was an excellent presentation, and I 100% agree that standardization of complication will definitely be a long way to understand the complications and prevent them. And one very other important thing which we understand from this presentation is the importance of registry. I'm so glad that the German hernia registry is so powerful, and it gives so much of information regarding the cases of hernia, their nature, the surgery, as well as the complication, which helps in development of new strategies to tackle the situation. I think the forum is open for discussion. If somebody wants to ask any questions to Professor Wolfgang.
Ramesh Agarwalla sir, Sarfraz sir, if you would like to ask some question.
I think it was a very lucid talk, very self-explanatory. And it was a bit of an eye-opener for me also about the recurrence part of it. I've never looked at recurrence the way he spoke about. And we thought recurrence is so, recurrence is recurrence. So what is about defining recurrence? And what about defining chronic pain? So thank you very much, Dr. Wolfgang. It's been a learning talk. We learned quite a bit. What you can look is in the chat box. If there are any questions from the delegates, Dr. Wolfgang can take those. So have a look on more in the chat box. Ask Kritika to pass it on to you. And if it is there, you can give it to Dr. Wolfgang and he can sort of answer.
There are no questions at presently, sir, in the chat box.
Okay. So Dr. Wolfgang, when we get the questions, we will take it on. Yes, Rajesh, sorry. Yeah.
Yeah. So then I'd like to thank Dr. Wolfgang for this insightful and an amazing talk. It had a lot of data, and as Kular sir rightly said, that this registry part is one of the things we all need to look into. We'll be getting the questions as and when, so we'll forward it to you and then we'll get the answers. So thank you so much, sir. Thank you, Ramesh Agarwalla sir. Thank you, Dr. Rajesh Kular sir, for being part of this event. Now we move on to our second session, which is the video-based discussion session, and we have curated videos describing complications of ventral hernia from across the length and breadth of India, as well as few videos from outside the country. So for this session, I would like to invite Dr. Tarun Mittal, who is the Senior Consultant, Laparoscopic and Bariatric Surgeon at Sir Gangaram Hospital, and Dr. Ashish J, who is Consultant, Laparoscopic and Hernia Surgeon at Sir Gangaram Hospital, to moderate this session. Over to Dr. Tarun and Dr. Ashish.
Thank you, Anmol. So for this, we will like to invite our panelists. I will request Dr. Wolfgang sir to please stay with us and have involved in the discussion of our session. Also, I request our next foreign faculty, Dr. Jaideep Raj Roy sir. We thank on behalf of Hernia Society of India.
I think we have lost video here.
Anmol, can you take over?
Yeah, so I would like to invite the panelists, Dr. Jaideep Raj Rao from Singapore. He's with us, and Dr. Wolfgang Reinpold is already here. Then Dr. Siddharth Tamaskar from Raipur, Ramakrishna Mission Hospital, and Dr. Ganesh Shenoy from AB Hospital, Bangalore. Hello, sir. We welcome you all to be the panelists for this session, and we have curated some videos, 14 videos in all, and we'll be going one by one, and will be the person who have contributed the video, they'll be presenting their video, and the questions will be opened up for the panelists to discuss.
Can you share the screen, Anmol?
Yeah, sure.
Can you guys hear me?
Yes.
So first video will invite Dr. Aparna. Dr. Aparna, ma'am, are you here?
Yes, Dr. Tarun, I'm
Ma'am,
here.
can you start the, yes, ma'am.
Just wanted to request if you could also allow my co-surgeon, Dr. Almas, on the on Zoom, because I think
okay, ma'am. We'll do it, ma'am.
Also allow my co-surgeon.
Doing it, ma'am.
Yes, thank you.
Can you start it, ma'am?
Yes, sure. So, good evening, everybody. I am Dr. Aparna Govil Bhaskar, and my co-surgeon. my co-surgeon is Dr. Almas, and we're going to present a short video of a very interesting and probably a very rare case of attacker migration which resulted into intestinal obstruction. So, can we start the video, Dr.
Yeah, sure, ma'am. Yeah.
So basically, this was a case of simple IPOM, and we did a case of hernia, and recovered uneventfully post-operatively, and she went home. And she presented with intestinal obstruction after about a month of surgery. And we conserved her and decompressed her for about 2 days. She was vitally stable. And this is post that we decided to go in with a diagnostic laparoscopy, and this is the picture that we saw inside once we went in. So there was a little bit of fluid inside, and there were a few additions to the mesh, but the mesh all in all looked all right. And there were a lot of fluid-filled dilated bowel loops. So we basically were trying to look for a cause of obstruction. Initially, we felt that probably this is the cause, this omentum, which you can see over here, which was densely stuck to the left side. But then we traced the entire small bowel, and from the DJ till the IC. And if you can see over here, these are all dilated bowel loops, and we reached the IC junction. And over here, there was a little narrowing, and we could see a little band which was there. So we felt that probably this band could be the cause for the obstruction over here, and it could be mostly at this band which is at the IC junction. And when we released the band, we saw that there was basically a tatter which had actually dislodged from the mesh and migrated and settled in the IC junction, and led to the formation of the band over there. So it was one of the tatters which probably had loosened and fell in the IC region and led to the formation of band and led to obstruction later on. So that was basically the whole case, and we were happy that we could manage it laparoscopically despite this being a case of intestinal obstruction. And she did very well later, because it was just a small band which needed to be dissected, and she recovered well. And the mesh was in place. There was no problem with the mesh. We removed 1 or 2 loose tackers, which we felt could again cause some problem, and did a suture fixation of those. So
thank you, ma'am. Thank you, ma'am, for the video. So my first question would be for Dr. Jaydeep Raj, sir. Sir, how could this complication would have been prevented? What are the steps the surgeon should take to prevent these complications?
Can you guys hear me?
Yes, sir.
Yes, you are audible.
Yes. So it's a really interesting case. I must say, very rare that tacker has fallen out and then caused as a nidus for this adhesion to form. So of course, some of the principles in IPOM is, of course, the tackers should be actually fixed properly, because these things, if it falls out, it can cause problems. Of course, we have done studies show that non-absorbable tackers, especially like these helical tackers, are much more dangerous than absorbable tackers. And so nowadays we actually just use absorbable tackers, and we don't use non-absorbable tackers anymore. Having said that, a lot of surgeries are being done with non-absorbable tackers, and this is really a very, very unusual case that tacker has fallen off and then caused this. Even sometimes tackers do fall off, and usually they don't cause problems. They present as maybe like a granuloma and things like that. So this one to cause this adhesion band is really a rare case. Otherwise, I look at the mesh has been placed pretty, it's flat and it's quite nice, and the tacking has been done in general. I see 1 or 2 loose tacks, but apart from that, the only suggestion that I can give is that absorbable tacks or just a few suture tacks would be beneficial. But we've done quite a lot of cases with tags, and we have not seen this kind. So it's really an unusual case.
Yes,
Thank
it is
you,
very
sir.
great. Thank you so much.
Thank you, sir. And now my next question would be to Dr. Wolfgang, sir. Sir, what do you think is the role of these absorbable tackers vis-a-vis also recurrence? What would be your preference now for using in IPOM if you want to use?
Yeah, as you all know, I'm not so convinced about the laparoscopic IPOM technique. I must admit, I never liked it because the idea of a foreign body material inside the abdominal cavity, the problem with the fixation of the mesh. You could see it on this in this video also that the mesh needs to be fixed with many tacks or sutures to the abdominal wall, and I don't know what happens if you fixate the mesh with long-term absorbable tackers. I'm not convinced that the mesh really stays in place. My feeling is when you use absorbable tackers, of course they are less risky for the bowel, but then there is no mesh fixation, and in many cases the mesh does not incorporate properly to the peritoneum and abdominal wall. So we use the lap IPOM technique only if no other options are possible. But this is my opinion. As I have shown you in my lecture, the results of lap IPOM repair in hernia med, they are good if it comes to infections and surgical site occurrences. The results are better compared to open repair. That's why my team and my unit, we have developed these minimal invasive techniques, Milos, eMilos, and now we have ETAP there. So there are other options than lap IPOM, and I think those will have the future.
Thank you, sir. There is now literature available that with the use of absorbable tag, the recurrence have increased vis-a-vis the non-absorbable tag. My next question would be to the Dr. Ganesh Shenoy, sir. Could this obstruction would have been managed differently? Could we have managed them conservative, like a post-IPOM obstruction adhesive? And what are the dangerous signs for the benefits of delegates when we have to intervene early? Dr. Ganesh.
Yeah. Dr. Aparna, congratulations. Very nice video and very well managed. Dr. Aparna has treated the patient conservatively for 2 days. So even in the case of any post-operative additions, maybe to the mesh or to the tacker, we usually wait for 24 to 48 hours to settle. If the patient doesn't settle in spite of conservative rate of management, it definitely warrants a diagnostic laparoscopy, provided if the CT scan or a X-ray abdomen is done and showing signs of obstruction. So here is the rate of complications. The take-home message, I would like to say that any loose tags, let it be observable or unobservable, tags has to be removed during the time of surgery. Any loose tags has to be removed, because even the observable taggers, because this patient presented 1 month following surgery. So even the observable taggers will remain at least for a month following surgery. So any loose tags, these complications can tend to occur, because if the tags migrate into the peritoneal cavity, there is a chance that it will sit on the seromuscular layer of the small bowel, similar obstruction. I don't think so that there is any other way to manage this, because Dr. Aparna has already waited for 48 hours for the admission of the patient.
Thank you, sir.
Thank you so much.
Now I invite Ashish to have the next video.
Right. Thank you, Tarun. And we have a slew of interesting videos after this one. So may I ask Dr. Anmol to please run the next video? And may I request Dr. Srijoy Patnaik, who's a laparoscopic surgeon from Calcutta with a special interest in hernia, to please speak on his video on mesh infection in IPOM. Dr. Srijoy, sir, are you there?
So Ashish, you can speak if he's not able to.
Okay. So on behalf of Dr. Srijoy, let me introduce you to this video.
Hello, I'm there.
Yeah, yes,
sir, please.
Dr.
Over to
Srijoy
you.
from Cuttack, not from Calcutta. So this was a case operated somewhere else 6 months back down the lane, and this video is very old, almost 10 years. It was happened in 2010. So this patient, young lady, was operated by another surgeon almost 3 months back before she reported to me. Initially, he reported to me a surgical site infection, and for 1 month, I managed it conservatively. In spite of that, it didn't go well. So he came up with a discharging sinus from one of the ports. So I had to undergo a diagnostic laparoscopy, and this was the result. I had to do a visualization of all the momentum that was stuck up, and you can see the entire mesh there. What I gathered that this mesh was most likely a polyurethane mesh, and I had to totally explant it out. So after explantation, the entire mesh was brought out in a bag, removed, and the area was irrigated with gentamicin, as Dr. Reinpold told. This is how it was extracted. And post-op, the patient followed up for 3 months, then lost for follow-up. Thank you.
Okay. Very interesting video, sir. Mesh infection is, of course, one of the banes of hernia surgery. I'd like to ask our panelist, Dr. Siddharth, sir, how do you think could have been prevented this kind of an infections? Do you think better sterilization techniques would have a role to play in prevention of these kind of infections?
Yeah, so there are certain important takeaway messages during the implantation of the mesh. First is that usually if there are multiple surgeries being done in the surgical operation theater, the hernia surgeries have to be the first, number one. And we do a compulsorily autoclaving or ETO of all the instruments which are being used. That's the number two step that we do. Number three is the very important thing is during the sizing of the defect, you have to be very cautious while you are handling the anterior abdominal wall. And thirdly, when the whole surgical team, when it is handling the mesh, that is taking the sample of the mesh from the packets and implanting it inside the abdominal cavity, they have to be cautious that the whole team has to change their surgical gloves and everything. And that is how we go ahead with that. And of course, there is a limited role of preoperative, that is the antibiotics given at the time, which is already usually done. So those are the things that we are very cautious about doing these.
Absolutely. I mean, all precautions should be taken very seriously. Agreed, sir. My next question is to Dr. Jaideep, sir. This mesh was removed laparoscopically. So would you have done the same thing, or would you have liked to have an alternative approaches to this management, like an open mesh removal?
No, I think, it's been managed correctly in the sense that I would also remove the mesh laparoscopically because then it gives you, if you want to do an operation the next time, then it can give you a new plane. If you're going to do the operations next time, either open or even if you can do it laparoscopically, that's fine. But if you want to do it next time open, then you have a fresh plane to do. So I agree with doing this laparoscopically, but I want to also add a comment about mesh infection in IPOM. So mesh infection in IPOM is extremely rare, or in keyhole for that matter. Apart from the general techniques of being asepsis, you have to have your hospital infection, general SSI infection rates, and if this kind of thing happens, you have to really go through an entire audit process for infection to make sure, because the whole idea of doing an IPOM or any MIS hernia with mesh implantation is that they have an extremely low mesh infection rate. So unless most of the time the mesh infection occurs if there's an underlying pathology, for example, there has been a missed bowel enterotomy, or serosal tear or something which has gotten worse, or extreme immune deficiency and stuff like that. So in general, or the patient has got some granulomatous disease like TB and things like that, HIV, and things that will make him really low immunity. Otherwise, the rates of infection should be very low. But
Absolutely.
for the treatment of it, yes, I would agree. The laparoscopic removal is probably the best.
Yeah, point well taken, sir. My next question is to Dr. Wolfgang, sir. We heard in your talk that you said almost 94% of the meshes can be salvaged in some way or the other. Do you think in this situation, this mesh could have been salvaged, in your opinion?
No. This trial from Sweden is the only trial that has published data of such high rates of mesh preserval rates, and they were really patient. You could see it on the slide. The longest follow-up of VAC treatment was I think more than 600 days. So extremely long. No. In this case, I would have removed the mesh exactly as it was done, and I think there is no chance of preserving the mesh.
Right, sir. Thank you so much for your opinion.
All the tackers removed, Ashish. Should all these tackers be removed? Should be very particular about removing all these metallic tackers, or some tackers can remain there.
Dr. Wolfgang, sir, should we remove all the tackers along with the mesh? I think we have lost connection with Dr. Wolfgang.
Well, you can remove as much as the tackers as possible. You don't have to go all out to remove tackers. The best, of course, if you remove most of it is good, but it's more important to remove the entire mesh, and that's more important than the tackers.
Okay, thank you so much. Dr. Ganesh Senoy, sir, what is your opinion on the role of atypical tuberculosis infection in these kind of mesh infections? Dr. Ganesh, are we with you? I think
Siddharth can answer.
Yeah.
Siddharth?
Yeah, sure. So I think that there is a very important role of atypical microbacterial infection, since in this patient, as you can see, the history suggests that it has occurred after 6 months of the implantation of the mesh. So usually what happens if it's in the first initial 10-15 days has happened is usually SSTI infection with staphylococcal. But if it occurs later on, then this is one of the most important reasons, that is the atypical microbacterial bacterial infections. And they are a little bit, sometimes a lot of people miss them. And you have to be very careful about diagnosing these infections, and they require a prolonged treatment for at least 3 to 6 months.
Right. Yeah. Point well taken. Thank you so much. Anmol? Anmol, are we audible?
Yeah. So next video is, I will request Dr. Yusuf. He's here. Dr. Yusuf, can you play? And
yeah. 50 years old lady with a high BMI of 40 kg per meter square, with a large recurrent incisional hernia and recurrent intestinal obstruction. And she had history of open mesh repair 5 years back. And now she was taken for surgery in a hospital in our city. And after some repair, on immediate post-operative period, she started developing severe abdominal distension with abdominal sepsis. So she was referred to us, and after initial evaluation and resuscitation, we took the patient for re-exploration. And on re-exploration, we opened the skin, the stitches, and we saw the mesh was just lying under the skin, and it was some sort of inlay repair. And there a lot of pressure was inside in the abdomen, and the bowel propelled out because of the abdominal compartment syndrome. And the meschoma was there, and we thought that the cause of recurrent obstruction was this meschoma. So bit by bit, we tried to remove the meschoma, but we saw that the adjacent bowel is gangrenous, and probably the previous operation, which was tried few days back, while dealing with the meschoma, the bowel got devascularized. And so in the immediate post-operative period, the patient had this bowel gangrene. And I think, we made the ileostomy, and we could not close the abdomen. So we just closed the skin, which was closable. And the plan is to go for a stomach closure after 2-3 months, and then if the patient returns for hernia repair later, then we can do a proper component separation technique. And we have seen that these patients who have near-death experience with hernia repair usually don't come back again for hernia repair. They better live with the hernia than trying another risky procedure. So this again for the question, Dr. Mittal, you can.
Thank you, Dr. Yusuf. So I would like to ask Dr. Ganesh Shenoy, sir. So what would be your tips and tricks for these patients who have undergone mesh hernioplasty before and have dense adhesions with the mesh of previous surgery? So any advice you would like to give to our delegates and to the faculty?
I mean, say there's nothing called as an ideal mesh. Even all the composite mesh by various companies, definitely they tend to have adhesions. When we have seen that, particularly we have seen when we have entered abdomen for some other pathology. For example, you have done an incisional hernia repair or IPOM plus repair, you have gone ahead in the next surgery for cholecystitis, then definitely you see some amount of adhesions. But we have seen that composite meshes, the adhesions to the composite meshes are easy to lyse compared to other meshes like interperitoneal mesh, Prolin mesh or a polyester mesh. You cannot prevent adhesions as such. Another thing what I would like to tell here is, see, meshoma is a very, very rare complication following an IPOM plus repair or open repair where the mesh contracts and forms like a ball. It's a very, very rare complications. To prevent a meshoma, I would like to say that the mesh has to be laid very flat during the time of initial placement. There should not be any folding of the mesh. And it has to be fixed properly so that it is flat. So any folding of the mesh can result in mesh contraction, leading to more fibrosis and a meshoma formation.
Thank you, sir. My next question would be to Dr. Jaideep, sir. Like in first surgery before Dr. Yusuf operated, they just did a bridging hernia repair vis-a-vis doing any component separation. So what option should a surgeon have in his field so that he can do the primary abdominal wall reconstruction can be done and midline can be closed? What should have been done in first surgery?
Yeah, so that's a great question. And as I always say that prevention is better than cure, firstly, and your first attempt at the surgery should be the best attempt. Because like this, once these disastrous complications happen, then it's very difficult to treat. So firstly, this lady is an obese patient with a BMI of 40. So in the primary surgery, I would do everything possible for her to lose weight before we attempt to repair the hernia. We know that obese patients have got much poorer outcomes and more than double recurrence rates that is there. So every attempt should be made for the patient to lose weight before we get. We also know now that, just bridging mesh in obese patients, you would have heard even last week, there was a meeting where Eric Pauli presented the data of inlay mesh, especially in obese patients, will lead to a very, very high recurrence rate, more than 50% recurrence rate. So how we can help to close this bridge is that one, reduce the BMI by weight loss, and two, attempts things like now what we do is a Botox injection. So we can inject Botox on either side of the abdomen, the external oblique, internal oblique, and transversus. And I would usually give about 50 units per muscle on each side. So a total of 150 units on either side. And then after about 4 to 6 weeks, then we would attempt to do the surgery. So whether you want to do this, open or robotic or laparoscopic is another discussion. You could do it even, if it's a large defect in the first, then open is fine. And this will also decrease the chance of you to do a component separation to bring the defect together. But it's important that every attempt should be made to bring the defect close. The other option to do is what is called as a peritoneoplasty. And if this hernia has been there for a long time, you can actually preserve the sac and actually double breast it, and then you can place that mesh over it. So these are some of the things that we would do to treat in the first instance.
Thank you, sir. Dr. Wolfgang, sir, are you there, sir? Dr. Wolfgang, sir? Dr. Wolfgang, sir?
I think we lost this connection.
Yeah. So I would ask Dr. Siddharth, what are the other options? Like in this, Dr. Yusuf just closed the skin and the abdominal wall he could not oppose. So what other options are there in this emergency surgery, redo surgery we are doing for a complication so that the abdominal wall can be closed? Anything which we can do?
Yeah, well, so what is happening is that actually I would not like to close the wall even in this case. We would like to leave it as a laparoscoma. That would be the better option, because as he has mentioned it, it is mostly because of a raised intra-abdominal pressure this has happened. And even if you try to close the skin, a lot of times, even though you might be able to close it, but later on it will lead to necrosis and then this thing. So our policy in such cases would be to do a laparoscoma, put in a negative pressure therapy for this patient, and then take it that way.
Thank you. The other option, Dr. Jaideep sir would like to ask is, how important is VAC therapy in this? A lot of development is happening in VAC therapy and VAC machines. Can we use them in this emergency setting and complication setting?
Yes. So actually, this case would be an ideal case to do a VAC dressing. So, as Dr. Siddharth mentioned, once you do your emergency surgery, instead of actually closing the abdomen straight away, you could actually, what we do, like a Bogoda bag or a plastic to wrap the bowel, and then bring as much as possible together, and you can do a VAC. One of the options that you can actually do is, of course, it's a bit more expensive, but that is a much later stage. I think in this stage, when there is an infection, then a VAC dressing would definitely be, an option. The only issue is that if you can't really close the bowel together, then you cannot be doing a VAC directly on the bowel. So you need to have a medium between that bowel and the VAC dressing. So you'd either, at least for a few days, you need to put like a Bogoda bag or a plastic to produce the VAC, and then so-called evaluate after a few days. And if the sepsis, everything is under control, then you can decide whether you want to close it with a biological mesh or a vicryl mesh, or as what the doctor has done is to just close the skin over.
Thank you, sir. So I invite Ashish to have the next video.
Sure. May I now request Dr. Piyush Patwa? He is a laparoscopic surgeon from Coimbatore, and I'd like him to speak on his video on intracutaneous fistula. Dr. Anmol, can you run the video, please? Dr. Piyush, are you there, sir?
Ashish, you can play it.
Okay. So let me go through the video. Can we? So this is about a fistula. The CT scan has already had shown a tract which is more broad, which is quite broad at the base.
Hello.
Yeah.
Hello.
Piyush is here. Piyush is here.
Oh, okay. Sure. Please go ahead, sir.
Hello.
Yes, Dr. Piyush, we are with you.
Yeah, this is a history goes like this. It's a 60-year-old female, obese female,
Piyush, we are not able to hear you. Ashish, you run the video only. You can start, Ashish.
Primary abdominal. After 3 months, it was almost like. Hello.
Yeah, better. You're better. Yeah.
Yeah. Can you hear me?
Yeah, better now.
Yeah. So this was the external opening, which you can see, which the primary surgeon identified, and she was almost like for next month, and finally she was referred for
you run the video?
Anmol, run the video.
I have taken her up for diagnostic laparoscopy. There were dense adhesions over the previous operated site, and mesh was also densely adhered to all the mesh area. And she presented to us with a large swelling other than the discharging sinus. So we converted the laparoscopy into laparotomy because there were adhesions were quite dense. Adhesiolysis was done, and here you can see the skin, the opening which we have taken with the sinus area, and fistula tract was probed, and there were through a bowel, and that the bowel is eroded with this mesh. So completely mesh was taken out, and as you can see here, the patient underwent the resection anastomosis of the involved bowel segment, and primary closure of the hernia was done, and patient was later taken off for the recurrence of the hernia.
Thank you, Dr. Piyush. We can make out that you had excised the mesh along with a segment of the bowel, and you had made a primary dissection anastomosis. Yeah, thank you so much. Point well taken. My first question is to Dr. Wolfgang Reinpold. Sir, are we with you?
Yeah, hello.
Yeah, sir, adhesions of the bowel to the mesh is a very known phenomenon. But what actually predisposes those adhesions, those flimsy adhesions, to actually progress to fistulization and erosion into the bowel? What actually is the process that goes on?
Yeah, I think it's a typical problem with these IPOM meshes. Of course, sometimes you can see such mesh erosions also after sublay repair. That is, you must know, sublay repair is not 100% safe for the bowel. This, of course, but you have always the barrier of the peritoneum, and of course, even the meshes which are now available for intraperitoneal use, they are better than the old-fashioned standard polypropylene meshes, but they are not, in my opinion, they are not safe. There's a coincidence. Yesterday, I did almost the same operation as I saw now with a patient in my unit, referred from another hospital, who had a lap IPOM repair 2 years ago with a fistula, with a multi-resistant MRSA, a multi-resistant staphylococcus infection, and we had to do the same. We had to remove the mesh, and we had to resect part of the small bowel and do an anastomosis. And in such cases, in my opinion, it's always better not to put in another mesh at the emergency operation or at the fistula resection operation, but closing the abdominal wall, if possible, with the sutures, and come back, let's say, 6 or 12 months later for definite re-incisional, recurrent incisional hernia repair. Right.
Okay. Thank you so much, sir. My next question is to Dr. Jaideep. Phasix meshes are in vogue now. Now, what would you suggest Phasix mesh to be implanted in such a case to prevent these kind of erosions and fistulizations? What is your experience on Phasix meshes?
Firstly, again, the situation of enterocutaneous fistula, when you say how does adhesion progress to a fistulization, this is not a natural physiology of how an adhesion progresses. Most of the time in meshes like this, if there's some grade 1 adhesions, they remain like that. Usually what happens is that during the surgery, there's either some serosal tears or a very micro enterotomy, which has this adhesion, and then the body tries to fight this off. If it can't fight it off, it becomes a full-blown mesh infection. But if it fights it out to a variable degree, then it can become chronic like this as an enterocutaneous fistula, where the body is actually localized it into a small place. So again, when I say that it's important that, not that all IPOM repairs get infected, it's very, very low. And most of the time it's not because of the adhesion, but because of, something that has happened intra-op, that has led to this. Now, phasic meshes, these meshes, they have a higher recurrence rates, and I will not recommend it for a primary repair unless there is some circumstances that will, things like, there's infection and stuff like that, and you can't use a composite mesh. We usually will use these meshes really as bailout. For example, in the previous case where, the abdomen was left open, things like trauma, and then, after a few days, you have to close the abdomen. Instead of just closing the skin, we put a biological mesh, telling the patient that you'll get around 40 to 50% recurrent, but then it's still better than 100% recurrence. So usually we'll use it in those circumstances rather than a primary repair. And using a phasic mesh will not so-called change your chance of getting infection. You can still get infection, but you'll get probably a higher recurrence rate.
Absolutely. Point well taken. My next question is to Dr. Ganesh Shenoy. Sir, we just heard Professor Wolfgang saying that he would not like to put another synthetic mesh right away. What is your take on a simultaneous repair of a hernia and a mesh in the setting of an enterocutaneous fistula?
Definitely, it's a contaminated field. The mesh has eroded into the small bowel, and they've done a resection anastomosis of the small bowel. So in such cases, I would recommend not to use a mesh, and clearly give a option to the patient that he or she may require a surgery at a later date. Well, you're going to put a mesh. But in this setting, it's a very controversial topic. In the clean contaminated field, people do recommend mesh, use of synthetic mesh in a case of clean contaminated field. But since the bowel has opened and the resection anastomosis has been performed, I would defer the placement of the mesh in this setting.
Great. So we'll come back to the discussion about
complications I've seen with the PTFE meshes, this enterocutaneous fistula. So I'd like to tell that the meshes which used to come with combination of proline and the PTFE mesh, proline facing the parietal side and the PTFE mesh facing the visceral side. So the thing here is the PTFE contracts more than the proline mesh. So when the PTFE contracts more, so the proline is exposed to the viscera. So such cases, I've seen that the bowel gets adherent to the proline mesh, exposed proline mesh, resulting in fistulization.
Absolutely. We'll come back to the discussion of mesh contamination in our subsequent slides. My next question is to Dr. Siddharth. Sir, what is your experience about laparoscopic management of such enterocutaneous fistulas?
So, I think I do not have an experience of managing such a case laparoscopically, and I think that the approach which has been done in this case is the approach that I would have also taken.
Sure. Okay. Point well taken, sir. Dr. Tarun, over to you.
So as you would know, this linear elbow injury in our ETP approach or a TAM approach is a very, very feared complication, and which we all are afraid of. So we will have 3 videos of these linear elbow injury one by one, and then we will have the discussion. First, I will request Dr. Mandar Gadgil to be here. Dr. Mandar, are you there?
Yeah, I'm here. Good evening to everyone.
For the video, he wants to say a few words and start the video. Just pause the video.
Yeah, so my video is essentially a clippet from one of our earlier series of ETEP rive stoppers. This is a 50 years old lady, BMI of around 30-32, with primary M3 3 centimeters umbilical hernia, primary umbilical hernia. We decided to go about with an ETEP rive stopper repair. Can we play the video now?
Anmol?
So as per my routine practice, I did the left retrorectal dissection first using 2 ports. During the crossover, the left PRS was incised, the falciform was taken down, and I was about to incise the right posterior rectus sheath. So after a couple of shots with the cautery, I realized that instead of a muscle, I am seeing yellow fat. So this is the warning sign that we should look for, the subcutaneous fat. Can you pause the video here for a minute? Yeah, so this is a subcutaneous fat which was opened inadvertently. The linea alba is seen on the medial side, on the left side of the slide that you see, and the right posterior sheath is as yet unincised, seen on the right side of the panel of the slide. Can you play it further? So we realized a mistake right here, by which time we had around a centimeter or two of a rent in the linea alba, just a couple of millimeters beyond. Can you please pause it here?
Yeah, it's paused.
Yeah, so just a couple of millimeters lateral to our previous incision, we took another incision with a cautery. There we could see the right rectus muscle, and so this is the correct incision. The previous incision was wrong, leading to an inadvertent opening up of the linea alba and creation of a neo hernia if this was missed altogether. So the dissection further was carried out in the routine in the expected plane. The hernia was tackled, and this rent, of course, which was an iatrogenic injury, was suture repaired, and a mesh covering this particular defect cranially was finally placed in the retrorectal plane. The further surgery went off quite uneventfully.
Thank you, Mandar. So now I request Ashish, can you, Anmol, can you play Ashish video? Ashish, are you there now?
Yeah. Yes. Let me go through this video. It was a small hernia with basically a divarication of recti. This was one of my earlier series. This is how we went into the left posterior rectus space. And while I was trying to cross over to the other side, you could see that the peritoneum has got injured. So this is the left PRS that I was dividing. Now, since I already got into the peritoneum, I decided to continue the rest of the dissection without the crossover. So now we are intra-abdominally, and this is the right PRS that we are dividing. That's the space below the right rectus muscle. I'm dividing the PRS. I'm going towards the cranial side. Now you'd realize here that I just needed to take down that flimsy retrolinear fat. But what happened actually is I have started dividing the linea alba inadvertently. I have not yet realized it. My instruments were clashing. So so I continued to divide it, assuming that I was taking down the fat. So you can see I've already started dividing the linea alba. And there I already have a linea alba injury. So this was missed. I continued doing the repair, the closure of the PRS. I put in a mesh. I put in a 20-25 mesh all around. And I continued closing the hernia as well as the divarication of the recti. Now, the point is that linea alba injury was missed. And this patient comes back to me a couple of weeks after the surgery with an obvious bulge above the umbilicus. So I realized when I went back, I saw the video, I realized that it was that linea alba injury that I missed. And that had caused an immediate post-op recurrence. Of course, that patient did not come back to me and probably got herself operated from a different surgeon. That's my experience.
Thank you, Dr. Ashish. Dr. Ganesh, sir?
Yeah.
Yeah, sir, your video is playing.
Yeah. So this is one of the first cases of TAM which I had done. This was a T-port TAM, a patient with a irreducible umbilical hernia of 2 centimeter defect. So here you can see that as I'm going here, I see the posterior rectus sheath, then the linea alba. I can see exactly the fibers of linea alba, the crisscross fibers of the linea alba, but I went above the linea alba. So I went above the linea alba was cut, and then I reached the subcutaneous space on the other side. Can you just pause? Can you just go behind a bit? So here you can see that I'm cutting the linea alba there, and I'm seeing there's the breach in the linea alba. So I did not realize, this was my first TAM case, I did not realize that at the linea alba. So I entered into the subcutaneous space. I didn't realize that because the patient had a divarication of recti, and I thought that this fat belongs to the divarication of the recti. So I did not realize that. Then in the process of going on the other side, I encountered the subcutaneous fat rather than the right rectus muscle. So that was the hernial sac being dissected. Here the main mistake was I did not go above the falciform ligament. What I mean to say that I did not go anterior to the falciform ligament and did not push the falciform ligament down. So all the dissection happened below the falciform ligament. So here you can see that's the anterior rectus sheath there. So I've entered the subcutaneous fat, and finally I realized that I didn't go above the falciform ligament. Then I started pushing the falciform ligament down to find the right rectus muscle there. So that was the right rectus muscle. You can see the right rectus muscle, the posterior rectus sheath below. I've already entered the anterior rectus sheath into the subcutaneous space. So this picture clearly depicts the right rectus muscle, then the posterior rectus sheath. Now I proceed with the dissection. After realization, I cut the posterior rectus sheath. Then this was the final picture which was seen. That was the subcutaneous fat. You can see the subcutaneous tissue, the right rectus muscle. Because this divarication of recti, I misunderstood the plane. Now what I did was I continued with the defect closure using a number 1 Prolene. The defect was closed. Since the patient had a divarication of recti, so now this is the picture you can see here. There's the right rectus muscle, the left rectus, and the false plane, that is the subcutaneous tissue. Then I proceeded with the closure of the rectus muscle. So I opposed the 2 rectus muscle with the 20 PDS. Then a 15 into 15 centimeter polypropylene mesh was placed in the retrorectus space. Then the flap which was raised was closed by 20 PDS. The Prolene mesh was fixed by sutures and few tacks, few observable tacks. Then the posterior rectus sheath was closed.
Thank you, Dr. Shenoy, sir. So I will ask few questions to the panelists. Dr. Wolfgang, sir, are you there, sir?
Yeah, I'm there.
So what are the pearls of wisdom to prevent these linea alba injuries? And also, would you like to comment on these videos? Any of you issue like you want to?
Very, very good videos and very honest. These things can happen, of course, and I presume all these were ETAP operations, right?
Yes, sir.
Yeah, ETAP operations. Yeah, we have many years ago. We started before we started with the Milos E-Milos project. We started the flank. The TAROP technique, which is now denominated TAROP by Philip Moisons. We published this technique very early in 2013 with a trans-abdominal retromuscular repair via the left flank, and we incised the left lateral posterior rectus sheath longitudinally in the left side, and then went medially and did the crossover. And when we started with this project, we had the same problem of damaging the linea alba. So so you have to, when you are in the rectus space and you try to do the crossover, don't cut the posterior rectus sheath at the medial edge of the medial edge of the rectus compartment, but go back laterally, let's say 1 centimeter or 1.5 centimeters, and incise the posterior rectus sheath there, and then you enter in the the chance of doing damage to the linea alba is much lower. Then you can be sure that you enter in the pre-peritoneal space, and then you can easily do the crossover. And as it was shown in all these videos, when you try to do the crossover and suddenly after doing an incision, you see you see subcutaneous fat tissue, then you are wrong. So when you do the true crossover and when you are incising the posterior rectus sheath medially, and you think you are in the space behind the linea alba, you always should go upwards and clear the linea alba from fat tissue, and then you should see the fascial structure of the linea alba. If you can't find it easily with some swipes of the laparoscopic instruments, you are wrong. That's my recommendation.
Thank you, sir. Now, Dr. Jaideep, sir, I would like to ask the question, as they have been telling that subcutaneous fat we can see. So how we diagnose and how to manage these linea alba injury whenever you see intraoperatively? What are the options available with us, sir?
So firstly, as I said before, the best is prevention is better than cure. And if I can start maybe with the indication, because in the 3 video, the first video is a primary umbilical hernia of 3 centimeter, and the third video was the primary umbilical hernia with 2 centimeter defect. So my personal opinion would be that maybe this operation to do a E-tap would be a slight overkill, because I feel that if the hernia is so small, we are actually doing much more. We are, distorting the normal anatomy with this crossover, things like that, rather than if you would have. So if it is a 2 centimeter umbilical hernia, I would actually maybe do this open, and all this would have been prevented. Same with maybe a 3 centimeter. So I would reserve E-tap for larger hernias, a bit more complex hernias, and that would be something to be prevented. Also, when there is a so-called diastasis involved together, we have to really see how bad the diastasis is. Sometimes if it is just minor, it may not require, the patient may not be actually symptomatic from the diastasis, but it's actually come for the umbilical hernia. And if that needs to be repaired, then maybe I think Wolfgang will probably do a myelose. I would do subcutaneous only, like you can do scolar kind of repair. But because here you just have a 2 centimeter umbilical hernia, his entire rectus is actually normal. But now we have so-called created this much bigger damage. So first would be a prevention. Then of course the second is experience. So obviously this sometimes in the learning curve, this thing happens where you mistake the subcutaneous fat. So you need to stick slightly lower, at the posterior sheath. I think that one already the surgeons have mentioned, to go slightly lower down. And the third issue is basically identifying the mishap when it happens and actually repairing it there and then. So these are some things that can be done to prevent this.
Thank you, sir. Dr. Ganesh, sir, how much should be the mesh overlap after where you have injured the linea alba? How much more we should go? How much more above we should go or below the linea alba injury where we have created? So we should treat it as a hernia?
Once you have, hernia alba is the central tendon of the abdominal wall. So once you have breached it, definitely there are chance of herniation in future. So what I've done in my video is, since there was a divarication of recti, I need to be extremely careful because there was a wide divarication of recti. So I was not careful enough in spite of recognizing the subcutaneous tissue. So probably what I mistaken was the subcutaneous tissue, the subcutaneous tissue over the linea alba. So I started, as Wolfgang Reinpold told, the linea alba has to be bared from the fatty tissue. So what I got confused was the fatty tissue still persisting on the linea alba. So I went ahead and thinking that it's the fatty tissue over the linea alba because the patient had a wide divarication of recti. I used the intraperitoneal TARP approach here. So basically, if it have gone above the falciform ligament and tried to push the falciform ligament down, taking it along the flap with the posterior rectus sheath, I wouldn't have encountered this injury. So I basically believe that you have to go above the falciform ligament, go anterior to the falciform ligament, push the falciform ligament down. This is one of the points to avoid the linea alba breach. Second thing is from the defect, at least you have to go 5 centimeters below the defect, because this was a primary umbilical hernia which I was dealing with. So 5 centimeters below the defect should be ideal.
Thank you, sir. So Ashish, now you can take over about this PRS rupture.
The next video is PRS rupture following a stapled repair. May I invite Dr. Anil Sharma, sir, from Max Super Specialty Hospital, Saket, to...
Anil Sharma, sir, is not there. I will be playing his video. So this is a patient of who had underwent a ETP approach mesh placement with a stapled. Post-op day 5, patient presented with abdominal wall abdominal distension and features of obstruction. So a CT scan was done, which showed that the bowel is herniated into the posterior rectus sheath. And here we have the findings. Anmol, can you play? So say here we see that staples you can see easily, which are seen there above. And here whole of the bowel, small bowel, lot of small bowel has gone inside. You can see the sutures also here, which have been placed to fix the mesh. Lot of adhesions were there. So we had to open this posterior rectus sheath, little bit incision was given, so that the bowel can come into the peritoneum. We have to be very careful for these adhesions, because it's a proline mesh. It's lucky that it's just 5th day, so they were not very hard adhesions of very dense adhesions. They were all able to be removed, and we could see this now. The mesh is there, and the posterior rectus sheath rupture is there. So then they decided to do an IPOM mesh for this hernia. Pritex mesh was used, and 15 by 15 with the help of transabdominal sutures and the tackers, they did the repair and could come out and salvage the situation, and patient did well post-operatively. So they are using these absorbable tackles with a layer, which a non-adhesive layer. So we'll play the next video also. Ashish.
Yeah. May I request Dr. Ganesh Shenoy to speak on his next video on PRS rupture. Dr. Anmol, can you please play the next video also? We'll take the questions later after this video together.
This was the same patient who underwent transabdominal retromuscular repair for a primary irreducible hernia. We discharged her the 2nd post-op day. She presented on the 6th post-op day. She was a known case of COPD who had violent cough in the post-operative period. So she presented on the 6th day with abdominal distension. A CT scan abdomen was done, which showed the herniation of the small bowel loops into the subcutaneous plane. So we did the diagnostic laparoscopy. We decided to take the patient in. We did the diagnostic laparoscopy, and during diagnostic laparoscopy, we found that the flap, which was closed during transabdominal retromuscular repair, had given way. It was closed with 20 PDS. The flap was given way. The proline mesh was sitting on the posterior rectus sheath. The rectus muscle, which was approximated, was given way, and the small bowel loops as herniated into the subcutaneous tissue. So here you can see that these were the sutures which are used to close the flap of the posterior rectus sheath. It was loosened. It had given way at some point. Then, since it was 6th or 7th post-op day, the adhesions were not very flimsy. So we did the hydrodissection to release the bowel from the adhesions.
Dr. Ganesh Shenoy, sir?
Play the video. Yeah, we can play, talk.
Yes.
Ashish, you can say.
Yeah, I think even the video is not running, or is it?
It's running.
Okay, once the adhesive lysis is done, we can see that the defect is there. The mesh had also crumpled up. So basically that has also led to the lot of adhesions of the small bowel. Now the mesh has been straightened, and transfacial sutures are being taken to straighten out the mesh, because the mesh seemed pretty okay, intact, not infected. So the mesh was allowed to be retained. And
audible?
Yeah,
yes, sir. Yes, sir, you're back.
So did not remove the mesh because there was no signs of infection. The proline mesh was again lifted up by transfacial sutures. Again, because it was very, very friable. And so we placed a large 20 to 15 centimeter paratex mesh covering the proline mesh and the defect. Then a regular IPOM repair was done, and the mesh was fixed with observable tackers. Then this patient got discharged on the second post-op day. Now almost 1.5 years follow-up. There is no recurrence of hernia.
Great. Thank you so much, sir, for the video. My first question is towards the panelists, Dr. Wolfgang. Sir, how after closure of the PRS, either by suturing or by stapled, how do you judge the tension in the suture line? And how do you actually manage if you feel that there is a tension on the suture line on the PRS?
Yeah, it's a very good question. In fact, we almost never, or let's say only if it's really possible with almost no tension, then we close the posterior rectus sheath. We don't close it. We close the peritoneum and we leave the posterior rectus sheath open with closed peritoneum in between in the midline, because even when we started with the reefs operations, with the open reefs operations many years ago, we had some cases of rupture of the posterior rectus sheath suture line with bowel obstructions. And the problem is when you do the reefs operation, be it open or any type of endoscopically, you cut the posterior rectus sheath at the medial edge, close to the linea alba. But you always have to bridge the width of the linea alba extension. So I give the advice to all surgeons: don't suture the posterior rectus sheath. Just leave it. But make sure that in between the peritoneum is closed. Then this allows you to place some kind of a little bit larger meshes, and of course you always have to close the anterior fascia and the hernia defect. This is key. So this is my advice. So we almost never do a suturing or stapling of the cut edges of the posterior rectus sheath.
Absolutely, sir. There is a growing group of surgeons who never close the PRS, and they just close the peritoneum PRS complex. So my next question towards Dr. Jaideep would be, sir, what is your opinion? Do you also would like to close the peritoneum PRS complex rather than bringing the PRS under tension?
Yes. You're right, because if you don't, because you have to, while doing the surgery, you have to see how it falls. And if there's any, actually the question is great, but the answer is difficult, because you have to make a judgment call whether this, is under tension or not. Most of the time, if there's, tension, then you have to do a bit more dissection, so that you can get it. Sometimes you can keep a bit of the sac and you can, use that, because you'll get some more of that sac space to help you to close. You don't need to close, the posterior rectus sheath per se, but so long as you get the peritoneum to cover over it, then that's good enough. So, as you rightly said, you can use that. And sometimes also you don't need to close it in a horizontal manner. I mean, this one, I'm not sure what was the initial size and things like that. But sometimes if you're doing so-called ETAP or a Robotar, or I mean those kind of things, you'll see that you may not be able to close it in midline. Then you can maybe close it even transversely. There's no hard and fast rule that you should be closing it in a straight line. So long as you get that peritoneum thing closed and the mesh doesn't so-called touch the bowel, if you're doing a so-called retrorectus repair, then that's good enough.
Yeah. Preserving the sac is actually a very good idea. What if you have disconnected the sac? Would you still go ahead and close it with a disconnected sac, like a peritoneal patch?
That's difficult because that part can become, if it's completely disconnected and does not have any side, that can be disconnected and can become a bit ischemic. Though actually, I mean, we don't have a lot of strong evidence either ways. Sometimes we do see where large amount of peritoneal dissection is being done, that it can become a bit ischemic and can get contracted. And sometimes it can give way, and that's where you can get the bowel getting into the spaces. But for this small sac, this peritoneal patch, I don't have much experience of that, and I'm not sure how much literature is there. I don't know whether Wolfgang, what is your experience on this peritoneal patch?
In such a situation where the peritoneum is no longer there, or maybe sometimes it's too flimsy to close it, then in such a situation I would do a tar, and then it's easy to close, and then again it's easy to close the posterior rectus sheath in the midline without tension.
Yeah, absolutely. I believe an unilateral tar should always be on the cards in case of tension. Dr. Ganesh, we are coming back to you. It's regarding your video and how you have dealt with your PRS rupture. Now, what other options apart from an IPOM can you deal with that PRS rupture, or is IPOM the only option of dealing with it?
No, here I felt like IPOM is the only salvage option.
Okay.
I didn't find any other option to deal with this problem because the rectus muscle had given way, the sutures had given way, which I used for the rectus approximation. That had given way. There was a wide divergence of recti, which I cannot resuture it because the rectus muscle was very, very friable for 7 days following surgery. Then again, the posterior rectus sheath had again also given way. So I felt and I feel that IPOM is the only salvage option available here in this case. I'd like to ask others what they would have done in these cases.
Yeah, what about using the omentum as a patch in that case? If you have a good amount of omentum, can you just suture the omentum to the PRS edges and the mesh? Would that help? Would that suffice?
We can ask Dr. Jaideep sir and Dr. Wolfgang.
No, I agree with Dr. Ganesh. I think that I would have done the same thing because that's the best possible salvage for this situation. It's fast because, as he correctly said, when this posterior rectus is all friable and you start to do more dissection at that time, it can cause more damage. So I think this, what was done here was I would do the exact same thing. I think it's
Okay.
I agree.
Right. Dr. Jaideep, we are coming back to you. When do you choose a stapled closure of the defect and the linea alba? When do you think that a stapled closure is good? Say for a divarication, wide divarication.
To be quite honest, I have not done a single staple closure for divarication because I think you need more of more mobilization and more this for you to apply a stapler. And I feel that you can put higher amount of tension. And I would rather use those 3 staple thing that is there that will pucker it up to actually suture it rather than put a stapler. So to be honest, I don't have any personal experience with staple. I've seen some nice videos by some of the surgeons, but I personally have not done any of that.
Right. Dr. Reinpold, what is your experience regarding the stapled closure of the PRS?
The same experience. My experience with staples is 0. I've seen nice videos, especially from Brazil, Ricardo Abdallah and his group, and they have done amazing stapling operations. But I don't have personal experience with the stapler.
Right, sir.
It's an option. It's definitely it is definitely an option.
Right, sir. Thank you so much. Over to you, Dr. Tarun.
Yeah. So I thank Dr. Vlad, Russian surgeon, who has helped us in providing 2 videos of his, and one of the videos is of post-TEP hematoma. I request Dr. Anurima, she's head of HOD of Tata Hospital, Jamshedpur, to have the video. Anmol, you play it, and Dr. Anurima will say it.
Thank you very much, Dr. Tarun. And thank you, Dr. Vlad Gurkar, for giving me this opportunity to talk about your video. This is the completion of the original surgery, where we can see the mesh has been placed flat on the posterior layer of the rectorectal space. And this is the second part, which is dealing with the complication. And here, after 12 hours of surgery, the patient had a drop of hemoglobin from 138 to 80 grams per liter and was taken back to the theatre. And yeah, play the video. So the ports were put back, and when we see, this is a large amount of blood collected in the retrorectal space above the mesh, and suction was done. And after suctioning, we can see almost around 700 ml of blood clots was evacuated by suctioning. And after suctioning, we see, suctioning is done, and we get, and this was around 100 ml that was taken out. And in the original surgery, no drain was kept, as we could see that it was a clean surgery and there was no collection. So after suctioning, we again see that there is no active bleeding that is going on. And since there is no active bleeding, then we can see the linea, semilunaris linea, very clear. There is no active bleeding from those areas. So again, suctioning is being done to look for the bleeding, and a drain has been kept in the retrorectal space after the clot has been evacuated. Even the peritoneal cavity has been inspected to see any collection or any bleeding. And here also a drain has been kept. And after keeping the drains, the procedure was ended because there was no active bleeding. There was nothing else that was done. And after 1 month, the patient was followed, and the hemoglobin of the patient was 120 grams.
Thank you, Dr. Anurima. So I will ask Dr. Wolfgang, sir. So how to prevent these hematoma? What precautions should we take during the primary surgery so that hematoma can be prevented?
Yeah, we had several similar situations after E-Milos operations and Milos operations. And what we do is we in patients who are under blood coagulation inhibitants, when we do these operations in those patients, we use as a standard, how do you call it? It's called 4-dry field. It's this powder. It's called, the German name is Stärke powder. It helps the blood clotting, and it's very, in our hand, it's very effective. But of course, you have to do very meticulous coagulation during the operation, and this is I'm sure this is a disadvantage compared to lab-IPOM in patients who are under coagulation inhibitants, who have a higher risk of afterbleed compared to lab-IPOM. You have to be very, very careful.
Thank you, sir. Dr. Jaideep, sir, do you place routinely drains in your ETP operations or when you're doing TAR? And if not, when do you place drains during the primary surgery?
So for managing hemostasis, of course, there's pre-operative, operative, and post-operative things that we can do to prevent bleeding. One is pre-operative. Of course, the patient history. make sure that they're not on aspirin or any blood thinners like Plavix and clopidogrel and stuff like that. That needs to be stopped at least a week before this kind of surgery. Then during surgery, of course, as Dr. Wolfgang said, meticulous dissection, using either diathermy or energy devices. And then usually you will have, by the end of the surgery, you have a feel on how this operation went. Sometimes it's very smooth and it's, everything is very clear. Sometimes there have been a bit of oozing and things like that. And then you have to make that judgment call. We usually use, like Wolfgang, we use things like, we have what is called as a hemosur. It's like a powder that we use. It's a hemostat. Or sometimes we use fibrin glue. But these hemostats are not a replacement for meticulous surgery. But of course, like this, when you do dissections, sometimes this bleeding occurs. So if I find that, the surgery was a bit bloody and things have been very oozy, patient has got a history of, being on anticoagulation and stuff like that, then these high risk cases, I would leave a drain, but routinely we don't leave a drain at all. And of course, a high degree of suspicion, in the post-op period. So I think post-op, when this, hematoma is there, so sometimes what you would need to do is that when you inflate air and go back in, you may find that it's not because of the air pressure has, already caused so-called hemostasis. So you need to bring that pressure down again and wait for some time to see if there's, bleeding. Then after thorough washing, the second time, definitely I would, apply something like a, hemosur or fibrin glue for hemostasis. And then at that time, of course, definitely also leave a drain. So I think what was done was, correct. Post-operative is the other issue. Those patients on anticoagulation, when to restart. So the cardiologist will always say, oh, you can start on the second day, third day. And we've had a lot of situations where my colleagues, their cases have come back with hematomas and things like that. I'm extremely anal about this. And, at least for a week, I don't start them on anticoagulation. You have to explain to the patient the risk of this bleeding versus risk of, so-called MI and CV, etc. So the risk of short-term stopping of anticoagulation is about, less than 5%. But the risk of bleeding after this restarting is about 20%. So risk versus benefit, it's better to restart slightly later.
Yeah, completely agree.
Dr. Siddharth, I would like to, when do you decide to intervene in these patients who have the posterior rectus sheath hematoma? Dr. Siddharth? So I will ask Dr. Ganesh. Dr. Ganesh, when should we intervene in these patients?
Prevention of, you want to say the prevention of retromuscular hematoma?
No, when do you intervene, like place a drain or reoperate? When do you decide?
Yeah, definitely. The patient, like significant drop in the hemoglobin, frank blood in the drain, significant drop in the hemoglobin, hemodynamic instability in any post-operative course, then definitely we have to intervene.
Okay. So
provided other subjects are ruled out.
Other specific question I would like to ask is the approach of managing hematoma different if you are placing an onlay mesh versus an underlay mesh? Dr. Jadip, would you like to comment?
To me, not much of a difference, but I have a low threshold for going in for hematoma because hematoma, of course, in a subcutaneous, it's got a higher chance of getting infected. But you can also get infected. Basically, a hematoma is a nidus for infection. So unless it's a really small, hematoma and there's, no other situation, yes, this can be left conservatively. But I think as Dr. Shenoy said, if the, there's so much drop in HB and, there's a bit of hemodynamic instability, I have a low threshold to go in to evacuate it because then the patient can have a much faster recovery post-op and you decrease the risk of, mesh infection.
The other thing which is there with these is that when they are having posterior hematoma, the mesh can also get uplifted and there are high chances of recurrence in posterior. Vis-a-vis only. Yes. So that is also the point which we should always take care of. And would Dr. Wolfgang would like to comment on this aspect, sir?
Yes. My policy is it's better to reoperate because if the hematoma is too big, if the patient has symptoms and discomfort related to the hematoma, you should reoperate. And apart from this, hematoma may prevent proper incorporation of the mesh into the abdominal wall, and this is very important. So if you have a large hematoma, the mesh floats, and it probably will never really be incorporated into the abdominal wall. So so it's better to reoperate. Of course, maybe if the hematoma, we check the hematoma by ultrasound, and if the hematoma is larger than, let's say, the volume of the hematoma is larger than, let's say, 150, 200 mils, I tend to reoperate.
And Dr. Siddharth, are you back with us? No. So, is there any option of drain placement, Dr. Jaideep sir? Not operate and just place the drain.
Sorry?
Drain placement. Just percutaneous drain placement. Do not operate and just place a drain. Is this an option for hematoma?
No. The reason is because if you put a drain on a hematoma, one, it may not drain it because it's not liquid, it's already coagulated. So there's no point in putting a drain because it will get blocked and you will not know anything. And worst of all, you've now put a connection from the outside cavity to your mesh and hematoma for worsening of the infection. So either if you have to make a judgment call, if it's small and okay, the patient is well, everything is comfortable, it's going to resolve, well, that's fine, you don't do anything, or you make a decision to go in and then evacuate it. So that would be, but just putting a percutaneous for this is not I wouldn't do that.
Thank you, sir. Ashish, you can take over.
Yeah, interesting discussions. Now we have another video by Dr. Vlad Burdakov again from the Russian Federation about that infected hematoma. I'd like Dr. Tarun to go ahead with explaining the video.
I again would like to thank Vlad. He could not come in because he's busy with his COVID duties. So he wanted to come in, but he said that you play the video and he gave us permission. So Anmol, can you play the video? The patient had a post-operative fever, EPRS unilateral TAR. It was a normal, uneventful surgery. And as you know, he does a beautiful surgery and he does a very beautiful TAR also. It was uneventful. And note, as usually, does not place the drain. Then post-operative 10 days, patient had for 2 days fever, and he had pain at the incision site, and patient was not feeling well. So CT scan was done, patient counts were used. So the provisional diagnosis of an infected hematoma was made, and then he generally do this ETP approach only rather than doing it anterior or a laparoscopic approach. So he just cleared all these stuff which was there, where we had taken sutures also, linear rectus sheet. We gave a good lavage, cleared all the debris, cleared all the muck which was there. Good suction. You have to make sure also that hemostasis is good because it is most of the time infected hematoma. One should always search for this. Here we can see the mesh is very well incorporated with the posterior rectus sheath, and so he decided, because of good incorporation, he decided that mesh should. He did not remove the mesh, and as you know, it's a good vascular area. Many times we can salvage the mesh because of this in this case. And post-operatively, 6 months down the line, he got the CT scan done. Patient was asymptomatic and no recurrence, no fever. Small amount of blood or some collection can be seen, but otherwise no. It was uneventful CT scan, and patient was managed well. Thank you, Ashish.
Thank you, Dr. Tarun. My first question would be towards Dr. Reinpold. Sir, this patient had presented with pain, abdominal pain, and there was fever, and he was not well. So, how would be your approach, your stepwise approach towards intervention in this patient?
Yeah, first of all, you have to rule out infection, and this is very, very decisive. If there is a large hematoma or liquid collection, then you can do a puncture and do an analysis for bacteria. And even in case of an bacterial infection, it's possible to salvage the mesh if the infection is not too old. In the first, let's say, 2 or 3 weeks, or maximum of 4 weeks after the operation, in most of the cases, the mesh can be salvaged, and you can do endoscopic or mini open reoperation, and you can use also back therapy, which we do if we have the very rare incidence of infection after Mylos operations. And my approach would be to salvage the mesh.
Right. Sir, would your radiologist be confident enough of telling you this is a infected hematoma or this is a non-infected hematoma?
Yeah, of course, in infection, the vascularization of the abdominal wall is better. That some radiologists can say it might be an infection, but it's not very reliable in my experience.
Right. Thank you so much, sir. My next question is towards to Dr. Jaideep. What would be your approach for intervention in this kind of an infected hematoma? We just saw blood going in endoscopically into the same plane, draining out the hematoma. Would you do it the same way? Would you prefer to do it an open laparotomy, or would you like to go in intra-abdominally and do it laparoscopically? Dr. Jaideep.
Yeah, so there's various ways of approaching, and it depends on your level of suspicion. So one is, of course, if it is a small this and you don't want to go in, one option is to actually intervention radiology can actually aspirate it and see, and you can send it for testing to see whether there's any infection. But the other aggressive approach is like what Blaine did, is to really go in and then wash it out thoroughly, send it again for testing, and do a solid irrigation. If you do it 8-10 liters, some studies have shown that the bacterial count can almost come to 0 by washing it thoroughly. And I think also, as Wolfgang said, vac therapy, if you're going to do it open. Whether to do it open or laparoscopically, I think is dependent on the surgeon and dependent on what you did the first time. So the first time you've done it, and you can go back into that same plane and wash it out, and then you can see whether you can salvage the mesh. That would be the best.
I believe it's all about experience. I agree.
It's always also very interesting to know how about mesh incorporation. In Blood's case, the mesh was nicely incorporated to the posterior rectus sheath. If that is not the case, if the mesh is still very loose, I would take it out.
Yeah, that's a great point. Yeah.
Yeah, that was supposed to be my next question. I'd like to ask the question to Dr. Ganesh. When would you decide for and against removal of the mesh in this case?
Against the same thing. I mean, the mesh was very well incorporated. If the mesh was loose, usually what happens, that's how we differentiate the CT scan. Basically, after a TP mesh repair, the differentiate between a seroma and a mesh infection. Usually in a seroma, the seroma lies above the mesh. But in a case of a mesh infection, the mesh floats in the fluid cavity. That's how we differentiate between a seroma and the mesh infection. This basically in a case of a TEP, but since the mesh was placed in the retromuscular space here, and the mesh is well incorporated already within a week of surgery, it's very well incorporated into the posterior rectus sheath. I wouldn't have attempted to remove the mesh, but if the mesh was floating, I would have removed the mesh. And it's good that the drain was placed in the second surgery.
Right. Dr. Siddharth, Dr. Siddharth, would you like to have a different opinion, or you also agree that the mesh was well incorporated and that it was not floating free? Do we have you, Dr. Siddharth? Do we have you with us? Great. So we can move on to the next video. Dr. Anmol, can we have the, yeah. Can I invite Dr. Mukund Khetan? No, the previous video. The previous video.
Sir, Ashish sir, am I audible?
Yeah, you are audible.
Yeah. So we'll be playing this Dr. Sarfraz sir's 2 videos, and then we'll go back to the.
Perfect. Yeah. Okay. So I invite Dr. Sarfraz sir to come.
Yeah, so this was a case where this patient had a contralateral TEP already done. And you can see that now that we have entered this page with difficulty, and we're trying to do it in a lot of smoke. And so I'm going to say 2 things. 1, there's a contralateral TEP done, and 2, we are operating in smoke. And see, already, and 3rd, we are using a harmonic. And see what we have done. So that's the bladder. We are not expecting this to be right at the top. We were expecting it to be at the bottom. But this comes as an end-on to you, right? It comes as an end-on because adhesion, so bladder is up. 1, 2, we're using a harmonic instead of using something which is, atraumatic, like an atraumatic raspers. And 3, this is already a violated space on the opposite side. And although this is not very bad, but still it's not good enough. And I'm just giving you a recap that not too much has been done, but with that little thing also, with poor vision, we can land up in injury. Of course, this was managed by putting in 1 more trocar, and then with triangulated ports, we sutured this with Vicryl interrupted sutures, and we kept a 4D catheter in this patient for 10 to 14 days. So this is the case. This is now open for discussion. I think you can ask the panelists the questions.
Dr. Tarun, would you like to take up the questions with the panelists? Dr. Tarun, are you with us?
Yeah, Dr. Jadip, sir?
Yes, I think Dr. Sarfraz has already answered given the answer in his talk that, the vision, is there, and if there's, smoke in this, the learning point would be that, you don't, proceed when the vision is not clear. But apart from that, yeah, I think sometimes these things happen, unfortunate incident, but still the bladder injury is not as bad as a bowel injury because, it can be repaired and there's minimal morbidity, compared to, hitting a bowel. So yes, visualization should be careful, especially in prior surgery. Those who have undergone previous pelvic surgeries, you have to have a high degree of suspicion and be extra careful, to place a catheter in place, which is already there here. So, I think that's about it.
Now, do you think TAPP would have been better?
Not really. Even in, we've had situations, we have seen videos where they've done TAPP and also injured the bladder. So I don't think there's any particular benefit over one. You have to start, of course, from the virgin area, and then ultimately you have to get to this area. So whether you go TAPP or initial if you're experienced in TAP, you can, do it. Otherwise, TAPP may be easier.
Yeah, because at least you are not you are going from lateral to medial, so you are from virgin to the difficult area. Sometimes in TP you have to dissect the retropubic space until otherwise you are not clear about the anatomy there.
Yeah, but in TP, you're going to do like a ETP, a bit extended TP where you'll go through from an area which is not been violated before.
Okay, sir. Okay, sir. Dr. Shenoy, sir. So how would you repair the urinary bladder? 1 layer, 2 layer, and when will you remove the Foley's? And what suture do you use?
Yeah, one tip I would like to give here before I answer your question.
Yes,
one
sir.
thing is the installation of the bladder with normal saline in such cases. Intraoperative installation of bladder with normal saline, it distends the bladder, so it helps in entering the proper plane. You know where the bladder is. In such reoperative cases, for example, the redo inguinal hernia surgery, or else in such cases where there is a lot of fibrosis in the space of Retzius, where you're unsure about the bladder, you fill the bladder with normal saline intraoperatively, which helps to distend the bladder and helps to delineate planes. So this is one of the tricks which can be followed intraoperatively. And to answer your question, definitely I would like to repair the bladder in 2 layers, keep the Foley's for 14 days.
Thank you, sir. Dr. Wolfgang, sir, and Dr. Jaideep would like to ask a question, both to you. Will you place a mesh in these bladder injuries post-TEP, in TEP?
Yes, I would do, yeah. I would place a mesh. No problem.
Yes, we would.
Yeah.
In males, definitely. Females, most of the time you should be okay.
Until unless we are dealing with some patient who has a BPH or a chronic UTI, we know the history. Most of the time we'll be able to deal it, manage this with a mesh placement.
Yeah.
Yeah. Thank you, sir. So next video, Anmol, can you play it of the sac ligation? Can you take, sir?
Yeah, so this is a giant hernia. We are doing with a conventional 3 midline ports, and you can see that the sac is being dissected off the cord structures, and then we ligated this. And while we were ligating, we realized this is too bulky. And something told us, okay, if it's bulky, let's go more distally to open. So we opened it very carefully at the distal end. And we realized, okay, there's a lot of stuff coming out, so let's bring it all back. And when we started doing that, we could actually reduce it. Now, we were not sure whether it's only fat or it contains a wall of the cecum because the right side. So we cut the, the distal sac under vision. And after we did that, we didn't undo the ligature at that moment. We parietalized it. We dissected this sac off the cord structures, which were always kept under view. So that was done. And we realized that we will have to open this stitch at some point. So you can see the vas and the gonadal at the back. So once this was done, we opened up the stitch. And yeah, so we opened up the stitch there. And you can make out that there is a lot of struggle there because we are in the 3 midline ports, right? This is not triangulated. In these situations, if it's a ETAP-like positions, it's easier. But if it's just standard ports, then it is a little difficult. But then we could suture with this. We didn't need to make any additional port, but we were ready to make an additional port. We were ready to dissect on the opposite side. But somehow we could manage, and therefore we did not make extra ports. With that, we could control this. But of course, this is now open to discussion. Why did this happen? Can we do something else? Can we identify patients where we can do an ETAP or a TAPP prior to the surgery? So all those questions, I leave it to the panel and the moderators.
Right. Thank you, sir, for the video. My first question would be towards Dr. Reinpold. When, sir, would you suspect a sliding hernia intraoperatively when you are doing a TEP?
So yeah, we do TAPP, and then of course we see what is inside the contents of the hernia sac. That gives you better visualization, and this is an advantage of TAPP procedure. You see what's inside the sac.
Right, but what if you are doing a TEP, sir?
When doing it, when doing a TEP, I would try to get the hernia sac completely out of the inguinal canal. So it's in this video, it was, in my opinion, a little bit too fast. The ligation, the sac was a little bit too fast. So I would try to get the hernia sac completely out of the inguinal canal.
Right. Dr. Jaideep, you are doing a TP and this hernia is irreducible. So it's not getting emptied. The contents are still there. The sac is not empty. So how would you manage this kind of an irreducible indirect inguinal hernia with a suspected sliding component?
Yeah, so of course, one is to have as the previous guys mentioned, to have a high degree of suspicion if it is not reducible, either pre-op or especially after surgery. When the patient is relaxed, when you try to reduce it, and if it's difficult to reduce, you must have a sliding hernia suspicion. A high degree of suspicion. Of course. Depending on your training, if you are an expert TEP surgeon, you can still proceed with it. Otherwise, a TAPP option would be better because you can have a better visualization. But if you're an expert TEP surgeon and you're going to go in TEP, you have to be careful because normally when things would actually fall off, but when you created the space and things are still bulging, then it's, you have to be very careful while reducing it. One option that you can actually do if you're not able to reduce is pull up the peritoneum and make a tiny cut on it and open and see from the TB itself what is going in. If it is small bowel, you can actually reduce it. Omentum, you can reduce this. And of course, you'll be able to identify a sliding hernia, colon that is there, and you can do that. So I would more so-called proximally, I would make a small enterotomy first and just have a look or lift up the peritoneum in a particular area and make sure it's just a peritoneum and there's nothing below to make a cut to see whether you can reduce this.
And anteriorly also, sir. More, not laterally, it should be anterior cut.
Yes, not more lateral, but more medial, because a sliding hernia will usually go laterally. So, you have a entire space just to actually have a look if your suspicion is high.
Right. We are coming back to Dr. Ganesh. We have seen Dr. Sarfaraz manage the case excellently well. He has not untied the suture. But what happens is if you untie the suture and if you have divided the omentum, it might just retract into the peritoneal cavity and it might continue to bleed. So how would you anticipate and manage this kind of a complication?
Yeah, he has not opened he has not opened the ligature. So what I would have done differently here was I would have placed the mesh. First, initially in the TEP approach, I would have placed the mesh. Then I would have seen intraperitoneally. I would have gone and seen intraperitoneally after placement of the mesh in the extraperitoneal space. Then see under vision what was ligated. Then I would have removed the sutures. Then under vision, I would have seen if there is any injury to the omentum or to the bowel. I would have gone intraperitoneally after placement of the mesh. Then whatever the peritoneal rent is, I would have closed intraperitoneally.
Yeah, that's a very good suggestion, sir. Dr. Siddharth?
He's not able to join.
Okay, so Dr. Reinpold, supposedly there is a small bowel injury and while you are dissecting the sac that way, would we still go ahead and put in a mesh in TP like you would do it for a bladder injury? For a small bowel injury with minimal spillage, would you still go ahead and put in a mesh?
That's a good question. With minimal spillage, I wouldn't put in a mesh. If there is no spillage, I probably would place a mesh. I would close the bowel with a suture, and of course, and I probably would put in a mesh if it's small bowel without spillage. If it's if there is spillage, I wouldn't put in a mesh. It's a very difficult question.
Right. How about a large gut without spillage, sir?
Pardon?
How about a large gut injury without spillage? Would you still be there? Yeah.
A large bowel injury.
Say a sliding colon.
Okay, large bowel injury. In a large bowel injury, I think you should not place a mesh.
Thank you so much, sir. Dr. Anmol?
So, this is the video of a lap IPOM, and during the adhesiolysis of lap IPOM, you have injured the, you can see the serosa and the mucosa, and you have injured the bowel. Few questions. This is a case scenario. So, first, I would like to ask Dr. Siddharth. Dr. Siddharth is here, not. So, I'd like to ask Dr. Ganesh how to prevent these entropies during the lap IPOM.
One is knowing the tips and tricks of adhesiolysis. Main thing is the entry. So Palmer's point is supposed to be the safest entry in case of any midline hernias. Then using of cold scissors, not to use any diathermy during adhesiolysis. You should need to have a very good cameraman who can able to handle and show you well with the 30-degree telescope. So meticulous adhesiolysis using cold scissors. So whenever you find a dense adhesions, you take a part of the posterior rectus sheath over the bowel. So it should be like the sheath, the posterior rectus sheath over the bowel, not the bowel over the posterior rectus sheath. So take a part of the posterior rectus sheath over the bowel during the time of adhesiolysis. If you have entered for a recurrent hernia, that is recurrence following a previous intraperitoneal mesh repair, and if the adhesions are dense, you can take a part of the mesh. Take a part of the mesh over the small bowel, or take a mesh over the small bowel and drop it down. Instead of going to try to find the plane between the bowel and the mesh, or the bowel and the abdominal wall, if in case of dense adhesion. So take a part of the abdominal wall, the posterior rectus sheath and the peritoneum over the small bowel.
Thank you, sir. So my next question to both Dr. Jaydeep and Dr. Wolfgang would be, so how do you decide when to place mesh in these injuries, bowel, small bowel, large bowel, in the IPOM? Dr. Wolfgang, sir, first, sir.
Yeah. Large bowel injury, I would not place a mesh. I would fix the bowel injury and finish the operation without mesh and come back after, let's say, 3 months and do a proper clean, clean non-contaminated repair. With the small bowel injury, if there is no spillage, I think it's possible to fix the bowel injury and put in an IPOM mesh. But it's debatable.
Yeah, I would do the exact same thing like Dr. Wolfgang and what even Dr. Ganesh talked about with tips and tricks would be absolutely the same. Both have put it very eloquently.
Sir, is there any option of coming in early, maybe within 7 days and after repair of bowel? Within 7 days, can you do a IPOM? Dr. Wolfgang, sir?
7 days. I would wait a little bit longer. If I opt for a 2-stage operation, I would wait longer. I would wait 3 months, unless the patient has severe symptoms due to the hernia. Then probably earlier.
Dr. Tarun, are you with us? Dr. Tarun? Anmol, can we go to the video? Dr. Khetan's video, please.
Yeah, sure.
Dr. Mukund Khetan is a senior consultant in Gangaram Hospital, New Delhi. Sir, would you like to comment on your video as it goes?
And Deep sir, if you reduce part of your bowel into the abdomen.
I think Dr. Khetan is not able to join. So, Dr. Ashish, can you tell us walk through this video a little bit?
Dr. Tarun, I'd like you to speak on this video, please.
This is a patient who had undergone ETP-RS approach incisional hernia, and had come to Dr. Khaitan for his laparoscopic placement of a had recurrent incisional hernia. So when they did a diagnostic laparoscopy, they could see a lot of adhesions which were there with the mesh. And they had promised this patient, here you can see the mesh, and the posterior rectus sheath is disrupted, and whole of the small bowel is densely adhered with the mesh. Here they had counseled the patient about laparoscopic approach, that they will do again do a laparoscopic approach, which Dr. Khaitan felt that they will not be able to do it, and they abandoned this procedure, and they did not did anything and just came out after doing a diagnostic laparoscopy. So, Dr. Ashish?
Dr. Ganesh, would you have done anything differently, or would you have done the same thing?
See, first of all, like I would have given an option to the patient that there is an option for an open repair in such cases, but definitely I would have spoken to the patient, then tried for an open repair.
Open repair is good for you. Great, sir. So I think that brings us to the end of this panel discussion. And
Ramesh Agarwalla sir would like to say anything, sir? Closing remarks, Dr. Ramesh sir?
Yes, thank you very much. I think it's been a very, very interesting webinar. It's been very, very educative. I would like to thank all of you guys for such a great show. Dr. Wolfgang, it's always a pleasure to listen to you. Thank you very much for participating in this webinar at such a short notice. Dr. Ashish Dey and Tarun Mittal, you were amazing. I think you possibly asked every possible question one could imagine. I could never imagine so many questions myself if I was moderating the session. You guys have done an amazing job. The other panelists, together with Dr. Wolfgang, Dr. Jaideep, Ganesh, and Siddharth, thank you for your sharing your vast experience. I think we have really given clear-cut take-home messages to the delegates about how to deal, how to avoid complications, but if they happen, how to deal with them. Anmol, you have been fascinating as a moderator. Sarfraz, you've always worked behind to chalk out the details for this webinar. Dr. Kullar for sharing his vast experience, and all the other surgeons, the 14 of them, amazing videos. And what I like about you guys is your honesty in bringing out your complications and sharing it. It's not possible for a surgeon to do all complications in his own lifetime. So how do you get experience? You learn from the complications. And if you've seen complications of others, then you are better prepared to avoid those complications. There's no point repeating those complications. So I'm really very grateful to all the 14 people who presented such excellent videos. And I think this is the first time we've had such a beautiful masterclass video-based panel discussion on ventral hernia complications. I compliment all you three guys, Anmol, Tarun, and Ashish, for conceptualizing together with Sarfraz this time, where you involved the other surgeons. And the other surgeons were so enthusiastic about the whole thing, presenting their own stuff. They were able to talk about it. So nothing could have been better. And last but not the least, I would like to thank Docplexus, Kritika, and Ashwin Thangavelu, who's always, again, behind the scenes, who's always so supportive. And I would like to thank everybody. I hope I have not missed out any name. If I have missed out, I'm very sorry. But thank you very, very much, you guys, for an excellent, excellent webinar. Thank you and good night.
Thank you, sir.
Thank you very much.
I think we can
so
have
much.
a good round of applause.
I would like to really congratulate you guys. I'd like to really congratulate you guys for a wonderful, wonderful meeting with fantastic videos. As I always say, it's always, nice to show, perfect videos and all that, but it takes even more courage to show, your complications and things. So we all learn from it. Nobody has, no complications. We all have had complications, but it's great to share this, and all of us can learn from it. I also, keep learning every time I see all this. So it's amazing. So congratulations. Thank you to Dr. Ramesh and entire society. It's truly been an honor, privilege, and a learning session for me too. And always nice to see you, Wolfgang. Hope we can also catch up sometime, in webinars for, the body-to-body interaction is always, great. So, but it's good to catch up with all of you. Realization, wonderful.
Dr. Wolfgang, sir, would you like to say anything?
Yes, I would like to say thank you very much for an amazing webinar. It was such a great honor and pleasure for me to participate. It was very great to see my friends from India again. And I would like to thank especially Dr. Ramesh for inviting me, and Dr. Amal, and Dr. Safaras, and all, and Rajesh. It has been very, very educative. I learned a lot, and I hope to see you soon personally. And I wish you a very nice evening and nice weekend. And thanks again for inviting me and making me part of this excellent webinar. I'm very proud. Thanks. Bye-bye.
Thank you, sir. Thank you, sir. Bye.
Thank you so much. Thank you. Thank you, Dr. Tarun. Thank you, Dr. Anmol.
Thank you, sir. Thank you, Ramesh, sir.
Wonderful organization.
Thanks for the wonderful
Bye.
Take care.
Bye. Take care.
Bye.